So up next, we have Dr. Jesse Nodora. He's an assistant professor here at UCSD in the Department of Family Medicine and Public Health, and also a member of the Moores Cancer Center.
Tough act to follow. I think that's what an Ignite session is supposed to look like. Fortunately, I didn't follow the instructions. So I'm going to be talking a little bit about a D&I project that just got funded to characterize colorectal cancer screening in fairly qualified health centers here in San Diego. This is the research team, 3 community health center partners and investigators, Dr. Rabin, Dr. Gupta, who's back here, and a medical anthropologist, Sam Hurst, and Lynn Liu, a statistician. This is funded by the American Cancer Society. It's a $1.7 million 5-year study. This basically characterizes cancer screening, I think, very well. Fear of the unknown, health literacy, patient-provider communication, and multicultural communication, particularly Muppet to human in this case. The problem in colorectal cancer screening in a nutshell is basically that you have low screening rates compared to the other 3 primary screenable cancers, breast and cervical, and especially among poor and underserved populations. The evidence-based interventions fall into 2 categories. The top one are strategies that have been, a strategy manual or approach that has been vetted by a national roundtable and the American Cancer Society, and then the Community Preventive Services Task Force has specific interventions for patient providers and clinics. The gaps are there. Limited time by the provider is a huge issue if you've been to primary care physician recently. The strategies are basically to increase screening and looking at how screening is actually happening and looking at implementation science to do that. These are the actual 3 aims. The first one is really to characterize what these FQHCs are doing right now. And the second one is to present them with a menu of those evidence-based interventions, and then assessing that in a trial. The framework that I'm using, or that we're using, a couple of them. One is the conceptual model of implementation research. This kind of lays out the evidence on the right-hand side, and then the intended outcomes on the left-hand side. The framework, one of the frameworks is actually the PRISM framework, and you can see there, this is all about, or largely about, the context. So you have the context at the intervention level, at the recipient level, and then even the broader internal and external environments. The stakeholder engagement, Dr. Gupta and I have been doing quite a bit of work in this area, particularly with fairly qualified health centers. We conducted pilot studies and really involved and try to understand at least the introductory elements of this problem, or this issue. So our goals are right there. It's basically a mixed method study, like so much of what you've been hearing today. This is the last aim. This is the actual randomized trial portion where you have a delayed intervention with basically a comparison group there at the bottom. So you'll see some of the complexity. The evaluation measures, particularly for the first aim, you'll see that we're talking about really doing interviews, a lot of qualitative work there, guided by the PRISM elements. And so these elements here, in addition to that, on aim 2, really a lot of what we're trying to figure out is, when you present folks with a menu for the evidence-based practices, how are they going to adapt them? Stearman has a framework to actually look at how that happens, and those are the elements there. So the last one, in terms of evaluation, it's a combination of re-aim and then a more traditional randomized trial. So you have that mixed method activity going on as well. And this is an example of what those measures look like in re-aim. So you look at like the absolute number, proportion of on the reach side, how we're picking that up, the data source, and then the level, provider and patient. And this, we hope, will advance D&I research in that way, but specifically number 3, I think, is probably the most important, development and application of D&I models, specific measures. we do hope to advance the field a little bit through that. Yeah, that's all I have.
Thank you so much. We can open it up for a question.
Hearing none, thank you. Yeah.
Thank you for the presentation. My question is whether you had a strategy to make it easier for the providers for recommending or delivering this program to their patients.
Do we have a way to make it easier for them?
Yeah, because usually providers have all the burden on themselves to deliver all these programs. So did you have any plan or strategy to help them to not have on top of other things that they have?
Yeah, yeah. So the provider right now is already recommending this screening, and largely a lot of this work is really about the federally qualified health center to have the ability to identify the person who is screen eligible, in this case 50 to 75, and not screened. So part of this is really going to be potentially very linked to the electronic health record system that the clinic has, and what kinds of information can be provided or given to the doctor to say it's time for your, in this case, largely the fecal immunochemical test to happen. Yeah.
Thank you.